You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This is the third and last in the series of Pediatric Cardiac Murmurs. It's a bonus focus on episode because we'll take everything we've learned about benign and pathologic murmurs and apply them to the bedside maneuvers we can use to be the deal breakers, worry or reassure. We listen to a lot of hearts, sometimes quickly, sometimes with more intention. And then one day you hear something on a toddler. Maybe it's a systolic murmur. You wonder, is this peripheral pulmonary stenosis or could it be pulmonic valve stenosis? How can you verify in your exam? Are there any maneuvers you can do to solidify your best assessment? When you listen, it does seem to change in intensity as the child breathes in and out. What should a pulmonic stenosis murmur do with inspiration? Or maybe an adolescent tells you that he feels dizzy during football practice. There's a systolic murmur. How can I verify whether he has a ventricular outflow tract problem? Once you've generated a differential diagnosis for the murmur you just heard, we can listen to what inspiration, expiration, valsalva, and hand grip do to that sound and clinch the diagnosis. Let's go through what inspiration and expiration do to your cardiac cycle. Remember that you will have several heartbeats within a given breath in or out. Whether you're inspiring or expiring, this affects your cardiac output, if only subtly. Now, let's say if you breathe 12 times a minute and your heart rate is, say, 60 per minute, and you spend a 1-to-2 ratio in inspiration and expiration, doing the math, doop-a-doop, that means that in any 1 minute, you're spending 20 beats per minute while inhaling and 40 beats per minute while exhaling. So what does that do to your cardiopulmonary physiology? When you inspire, you increase your preload. The diaphragm contracts and there is a drop in pressure around the right atrium, which helps blood from the superior vena cava drop right into the right atrium. In addition, when the diaphragm contracts, intra-abdominal pressures increase slightly. They give that little extra push up the inferior vena cava. So during inspiration, you get blood rushing into your right atrium, aka increased preload, for those two reasons. The drop in intrathoracic pressure, it sucks blood in from the superior vena cava, and the bump up in intra-abdominal pressure pushes the blood up from the inferior vena cava into the right atrium. Inspiration, increased preload. Since inspiration makes intrathoracic pressures drop, there is less pulmonary venous resistance and blood in that circuit, and so it pools in the lungs. Blood pooling in the pulmonary circuit means that there is less forward flow into the left heart. Your heart is beating the whole time you're inspiring, and you will see a drop in the left ventricular output. A drop in output means a slight drop in systemic blood pressure, and we know what that means. A decrease in vagal tone will increase the heart rate. So if your stroke volume is decreasing, you have to make up for it somehow, so you slightly increase your heart rate. That is, if you want to keep your cardiac output up and not pass out, you need to increase your heart rate just slightly. So during inspiration, are you ready for this? You're sucking in air, and for the next several heartbeats, your preload will increase. Blood will pool in your lungs. You'll have a drop in flow to your left heart, a drop in blood pressure, and an increase in heart rate. Right-sided murmurs tend to increase with inspiration because of that increased venous return. So that means whether we are talking systole or diastole, it doesn't matter. On inspiration, right-sided murmurs increase because of increase in preload. That means pulmonic stenosis will increase in intensity during systole. Pulmonic regurgitation will both increase in intensity during diastole, and tricuspid stenosis and tricuspid regurgitation will also increase in intensity with inspiration. The right-sided murmurs increase in inspiration because there's increased preload and flow on the right side of the heart. If that's a whole lot, then fine. Right-sided murmurs, pulmonic and tricuspid murmurs, will increase with rinspiration. Right inspiration, increase. Rinspiration. For example, you're seeing a 9-year-old who's previously healthy. His parents were told he has a murmur. They're watching it. He comes in with a benign-sounding cough. You listen over his left sternal border. You're just minding your own business, listening to his heart, because that's what a good doctor does, right? And you hear a little extra turbulence during diastole. Over the pulmonic area, diastole, that should be pulmonary regurgitation. Were you expecting that? Hard to tell. The parents don't know exactly what it is. Now, pulmonary regurgitation is not normal, but if it's mild, it's just a watch and wait approach. Let's apply what we've just learned. Maybe this will help us to be reassured a little bit, or at least know what the next steps are. What do we do? Well, you've already figured out that the most likely cause is just putting it together where you're listening and where in the cardiac cycle the murmur is heard. You then just listen and observe when he's breathing in and out. What happens? Right-sided murmurs get louder with rinspiration. You hear it. To be sure, you have him take a slow, deep breath in and... What happens with expiration? Well, the opposite. Not so fast. Let's go through this too in depth. Again, you spend a lot of your time in expiration, and if you're breathing normally, you'll spend the majority of your cardiac cycle breathing out. During expiration, your diaphragm relaxes. Your intrathoracic pressures normalize, which means there's no pulling of blood back into the right atrium, and so, relatively speaking, preload will slightly decrease. Your pulmonary circuit gets compressed during expiration, pushing more blood forward into the left heart. Your left heart is very happy. Its blood flow is better, which means better cardiac output, better systemic blood pressure, and no need to compensate with an increase in heart rate. So as your blood pressure improves, your heart rate drops slightly. Again, if that is all a bit much, use your own self to think it through. When do you feel more at ease, taking a breath in or breathing out slowly? There's a reason you have a bit of a better sense of ease when you breathe out. Your vagal tone is better. Your heart rate is slightly decreased. Well, all of that increase in blood flow to the left side of the heart, what is it going to do? What do you think? What will that do to left-sided murmurs? Yep. Expiration will make left-sided murmurs louder because during expiration, you have better left heart flow. So, aortic stenosis in systole or aortic regurgitation in diastole, both of them will get louder with expiration. Mitral regurgitation in systole or stenosis in diastole will get louder in expiration. If all that fails, then you can remember that left-sided murmurs get louder with lexpiration. Okay, thanks for sticking with me here. There's a reason for all this. First, you can confirm your own suspicions with inspiration and expiration, but also it's important to remember and really understand the physiology when you go then to do the maneuvers. Let's talk Valsalva. Valsalva is actually a dynamic maneuver with dynamic physiologic changes happening, whether it's early, middle, or late Valsalva. But to keep things simple, we'll just talk about the net effect of Valsalva. This one's easier. Valsalva makes most murmurs softer. Valsalva valve softer. We'll just leave it at that for now. Hand grip is almost the opposite. When you have someone tighten their fist, that increases afterload slightly. Increase the grip, increase the murmur. So, just to flesh that out, let's say you see a school-aged child who comes to you for a chronic cough. He seems well, he has reassuring vital signs, but you hear this. It doesn't radiate. It's just there at the left lower sternal border. When you ask his mother if she's ever been told that her son has a murmur, she nods but can't remember all the details. Just they were going to watch it. The boy has not been to his doctor in some time. They usually go to the ED for their episodic care. It kind of sounds like a VSD, maybe even a moderate VSD that was supposed to be watched and possibly intervened on at some time. We can apply our knowledge of preload and afterload to see if it fits. We have him tighten his fists like the Hulk. We can increase afterload. Increasing afterload should make most murmurs increase. Since most VSDs are a left to right shunt and you increase the afterload, there's more pressure in the left ventricle than there normally would be, and therefore more blood flow from the left ventricle through the VSD into the right ventricle. You get him to grip like a superhero, and yes, the systolic component is louder. What if you get him to bear down? Well, it's a little harder to get a school-aged child to do. They will kind of look at you like you're crazy. But if you were to get him to pretend an elephant is sitting on his tummy, push him back up. You will get a decrease in preload and a decrease in the murmur. There is simply less blood rushing from the pulmonary veins and left atrium into the left ventricle during diastole, and so less blood in the left ventricle to spill into the right ventricle during systole. So indeed, you hear this. And it's louder on hand grip. For most murmurs, Valsalva will valve soften the murmur, and hand grip will intensify them. Keep this in mind because we're about to go over one of the auscultation bad boys that breaks this rule. Remember, normally, Valsalva valsoften, hand grip intensifies, unless you got hypertrophic cardiomyopathy. If you just remember Valsalva valsoftens, hand grip intensifies, and hokum is that rebel, then you're good. But let's talk a little bit more about why hokum does just the opposite of what we expect. Hypertrophic obstructive cardiomyopathy is an inherited disorder. Many people have it without even knowing because it varies in symptoms from person to person and their level of activity. Intraventricular septum, it's asymmetrically hypertrophied. It's like a ballooning of hypertrophic muscle just under the aortic valve. So everyday activity, when cardiac output is at baseline, enough blood makes its way up and over that ballooned out septal wall and into the aorta and into the systemic circulation. There's not a lot of stress, and that's okay at baseline. But during exercise or cardiovascular stress, the left ventricle can be pumping more vigorously, only to be met by an obstructive area that will impede normal flow. This is why athletes are at risk for syncope or even cardiac arrest when they don't know about their hokum and they stress themselves out and their cardiac output. Here's the murmur you'll hear: a ventricular outflow obstruction during systole. The pathophysiology of hand grip and Valsalva is an interesting one in Hokum. It's like aortic stenosis, but instead of a fixed lesion, it's dynamic. Remember, the ballooning out of the interventricular septum into the left ventricle will change in relationship to the aortic outflow tract with every beat. When you increase afterload, you're increasing pressures within the left ventricle. This helps to push back the interventricular septum and stent out the ventricular outflow. So hand grip usually decreases the murmur in hypertrophic obstructive cardiomyopathy. Think about that for a second. We're keeping the left ventricle a little more distended because of the hand grip afterload effect, which stents open the outflow tract to the aorta. Less impingement, less murmur. It's kind of like PEEP. Hokum is the rebel, the exception. Hokum hand grip hides the murmur. That's a lot of little nuggets to pack into this Focus On episode, but let's recap. Rinspiration increases right-sided murmurs, pulmonic and tricuspid murmurs. So you are hearing a systolic murmur on the left upper sternal border, and you think, pulmonary stenosis? Let me have this child take a big, slow, deep breath, and lo and behold, that pulmonic stenosis murmur gets louder with inspiration, with rinspiration. Pulmonic stenosis, pulmonic regurgitation, tricuspid stenosis, tricuspid regurgitation all increase with inspiration, because with inspiration, there's an increase in preload. It's kind of inspiration's thing to increase preload. Preload affects the right side of the heart the most. So rinspiration increases right-sided murmurs. Lexpiration increases left-sided murmurs. During expiration, your pulmonary circuit gets compressed and more blood flows into the left side of the heart. Increased blood flow, increased murmur. This is why left-sided murmurs, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, all of them will get louder when there's more return to the left ventricle. Lexpiration will increase left-sided murmurs. Bring it all together. Listen for that murmur. Really listen. Where on the chest are you hearing it? Aortic, pulmonary, tricuspid, mitral? Is it systolic? Diastolic? Is it superiorly stenotic and inferiorly insufficient? Is it diabolically diametric in diastole? When you've decided the anatomic area, then whether stenotic or insufficient, you can verify whether it increases with inspiration, a right-sided murmur, or increases with expiration, a left-sided murmur. Thinking, re-listening, coming up with a differential diagnosis. Then and only then can you cinch the deal with a maneuver. Valsalva softens most murmurs. In fact, it valsoftens them. Hand grip intensifies most murmurs. But there is that bad boy murmur, that rebel hokum. The opposite. Valsalva will make hokum worse. In hokum, hand grip hides the murmur. In general, Valsalva valsoftens, hand grip intensifies, hokum does the opposite. A hypertrophic oppositional disorder. Okay, now that we've beat that into our brains, listen to your next patient's heart beat, and bring it all together. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.